Good evening, friends. I welcome you all to this CCI webinar on the pulmonary vasculitis from rarity to clarity. Friends, it's really commendable and needs a huge applaud to the CCI organizers, Dr. Krishna Bhai, Dr. Vijay, Dr. Shivani, Dr. Ravi, Dr. Etri, the CCI President, Dr. Dubey, and Secretary, Dr. Maske, for meticulously organizing these webinars every Thursday and bringing us all pulmonologists together on a platform. Today's webinar revolves around a rare and challenging entity, pulmonary vasculitis. The plan and the flow of the today's webinar would be, first we would have 3 talks from our 3 esteemed faculties, followed by a panel discussion and then a case presentation. We would probably change the flow that followed by the presentation. We would also take up a case and then a panel discussion. So the first talk would be by Dr. Naeem. He would deliver a talk on the clinical features and diagnosis of pulmonary vasculitis. This would be followed by Dr. Nikhil Gupta, who would talk about radiology in pulmonary vasculitis. Dr. Nikhil is a radiologist, and we are honored to have a rheumatologist on board where we'll be setting up a flavor of MDD. So Dr. Ramesh Jois from Bengaluru would deliver a talk and tips and tricks in the diagnosis of pulmonary vasculitis. So let's begin with Dr. Naeem Dar. Dr. Dar, all yours.
A very good evening to all of you. I am thankful to CCI providing me this opportunity to present myself via this webinar. Thank you to Dr. Sonia Dalal for a nice introduction. And I will straight away move to my assigned topic, pulmonary vasculitis, clinical features, and diagnostic evaluation. So by definition, pulmonary vasculitis, it's an inflammation and destruction of pulmonary vasculature due to a variety of immunological mechanisms. So when should we suspect a patient is having pulmonary vasculitis? Besides having overlap in the clinical signs and symptoms, there are some clinical scenarios where we should suspect pulmonary or systemic vasculitis, which includes diffuse alveolar hemorrhage, acute glomerulonephritis, pulmonary renal syndrome, which is a combination of DH and GN, destructive upper airway lesions, pulmonary nodules with cavitations, palpable purpura, and a multi-system disease which has combination of signs and symptoms involving multiple organ systems. And based upon which vasculature is involved, it will be a large vessel, medium vessel, and small vessel vasculitis. In large vessel, Takayasu and giant cell arteritis. In medium vessel, it's Kawasaki and polyarteritis nodosa. And importantly, in small vessel vasculitis, we will be dealing with the ANCA-associated vasculitis consisting of microscopic polyangiitis, granulomatosis polyangiitis, and EGPA, which was previously called Churg-Strauss, a variable vessel vasculitis Behçet's. Based on this classification, already as I explained, so the variable vessel vasculitis, which includes Behçet's, single organ vasculitis, importantly cutaneous arteritis, and primary central nervous system vasculitis. And there is vasculitis associated with systemic disease like lupus, rheumatoid, and sarcoid, and vasculitis associated with probable etiology, hepatitis B, C, and drug-associated and syphilis-associated vasculitis. Moving forward, based upon the vessel involved, since we have to see which of them is affecting the pulmonary system. In large vessel, it's the Takayasu. In medium vessel, rare pulmonary involvement. Small vessel is having a frequent pulmonary involvement, as we can see in GPA, MP, and EGPA. And in immune complex mediated, it is anti-GBM and hypercomplementinemic urticarial vasculitis. Based upon the ANCA vasculitis, we can see here by the percentage in this tabulated form that the upper airway pulmonary parenchymal disease and the alveolar hemorrhage, most importantly, having its percentage in granulomatosis polyangiitis, having 90 to 95% upper airway and 50 to 85% parenchymal involvement with alveolar hemorrhage of 5 to 15%. The various pulmonary involvement presentations in pulmonary vasculitis will be upper and lower airway involvement, the interstitial disease, alveolar hemorrhage, pulmonary artery stenosis, the parenchymal involvement in the form of nodules and consolidation along with the cavitation. So, if we move on to the diagnostic evaluation in pulmonary vasculitis, the clinical assessment will be the like cough, breathlessness, chest discomfort, hemoptysis, and other variable signs and symptoms. To aid our diagnosis, we have to take the help from serological testing, imaging, bronchoscopy, and histopathology. So the clinical, you can see a nasal septal perforation, saddle nose, sclerites, tracheal, subglottic tracheal stenosis, a palpable purpura. And in the laboratory parameters which aid us in the diagnosis, a raised CRP, increased ESR, elevated platelet count, eosinophilia in EGPA, anemia, importantly, a drop in hemoglobin in diffuse alveolar hemorrhage. In urine analysis, there will be proteinuria, raised creatinine and urea, and active sediments and red cell casts. When we go for ANCA testing, it is indirect immunofluorescence assay, which is more sensitive, and ELISA antigen specific, which is more specific in its aiding the diagnosis. Here in this diagram, we can see the distribution of C ANCA and P ANCA along with the anti-protease 3 and anti-MPO in various small vessel vasculitis. So, what are the various clinical indications when we should go ahead with the ANCA testing? It's glomerulonephritis, diffuse alveolar hemorrhage, multiple lung nodules, subglottic tracheal stenosis, retroorbital mass, sclerites, as I already described it. This is a flowchart diagram which helps us in figuring out and aiding the diagnostic pathway in association with the immunofluorescence assay and ELISA testing to see the positivity and negativity in various small vessel vasculitis. The radiological presentation, a destructed nasal septum. Here in this picture, we can see traction bronchiectasis is present there, along with in this typical presentation, bilateral consolidation, nodularity, and cavitating pulmonary nodules. Bronchoscopy is very important in aiding the diagnosis. It helps us to differentiate in infective causes by bronchoalveolar lavage, in diffuse alveolar hemorrhage, a serial sequential ball along with the hemocytin-laden macrophages. TBLB for histopathological diagnosis is important, and ball fluid along with TBLB in cases of lung nodules helps us to evaluate fungal and TB causes. Here, a sequential ball in diffuse alveolar hemorrhage, you can see the pictorial presentation. Along with histopathology, the biopsy becomes very important, and the important site in biopsy will be kidney and skin, If we are not having this involvement, the lung biopsy has a role. However, the diagnostic yield in kidney and skin biopsy is above 90%, while as in lungs, in transbronchial or CT guided biopsy, it's less than 50%, and open lung biopsy having a complication rate high, though the yield is around 90%. This is the tabulated form of all the lab parameters which I have already discussed with you. And here is the take home message: diagnosis needs clinical, radiological, and histopathological consensus. Pulmonary infection, connective tissue diseases, malignancies, and hypersensitive disorders should be considered in differential. Classification of vasculitis is based on the vessel involved, a low threshold for CT diagnosis, and diagnosing a primary pulmonary vasculitis are most challenging in view of their overlap in signs and symptoms along with non-specific presentations. I welcome you all on 8th and 9th of June. Kindly book your dates for the 5th CCI Con. Thank you very much for this presentation.
Thank you, Dr. Naeem. Uh, First of all, I would like to thank Dr. Krishna and CCI family for having me here. I am Dr. Nikhil Gupta, Consultant Radiodiagnosis and Imaging, SPS Hospitals, Ludhiana. And today we will be discussing about the radiological approach to pulmonary vasculitis. These are the clinical and radiological scenarios which, when present, should give you a clue of vasculitis, like the deforming ulcerative upper vascular regions, palpable purpura, peripheral neuropathy, rapidly progressive glomerulonephritis, a pulmonary renal syndrome, chest imaging findings on nodular or cavitary diseases, and diffuse alveolar hemorrhage. Coming to the classification of vasculitis, these are the vasculitis which are given in the Chapel-Hill nomenclature. These are large vessel, including GCA, Takayasu, medium vessel, including PAN, Kawasaki, small vessel, including Wegener's, CSS, microscopic cholangitis, HSP, essential cryoglobulinemia, vasculitis. So this is the diagram showing the same. These are the vasculitis not involved in the Chapel-Hill classifications, including good pastures, Behçet's, polymyositis, dermatomyositis, APLA, inflammatory bowel, drug-induced or paraneoplastic syndromes. These are the clinical characteristics of pulmonary vasculitis syndromes. So, pulmonary renal syndrome is seen in good pastures, microscopic polyangiitis, Wegener, Church-Strauss, or SLE. Similarly, pulmonary hemorrhage can be seen in any of these, and it is generally rare in rheumatoid arthritis, Church-Strauss, and polyarthritis nodosa. Pulmonary artery aneurysms are seen in giant cell arteritis, post-stenosis dilatations in Takayasu arteritis, and in Behçet's and Eustoven syndrome. Chronic pulmonary hypertension is generally seen in giant cell arteritis, Takayasu arteritis in late stages, rheumatoid arthritis, systemic sclerosis, mixed connective tissue disorder, and SLE. Coming to large vessel vasculitis, first is the giant cell arteritis. Here there is the involvement of large vessels, and involvement of pulmonary artery is rare. Here we can see involvement of ascending aorta. There is diffuse circumferential thickening of the ascending aorta. Then coming to the next one, Takayasu arteritis. Here there is intimal proliferation and necrosis, leading to segmental stenosis and post-stenotic aneurysms. In early phases, there is concentric mural thickening as seen here, and the other abnormalities like dilatation of the arch, wavy appearing descending aorta, and premature aortic calcifications can be seen. These cause narrowing of the lumen. Uh, Pulmonary arteries is involved in very few number of cases. In late stages, we can see vascular fibrosis and destruction of the elastic tissue. So stenosis can occur. Here we can see concentric calcification, and here we can see left subclavian artery stenosis. Then coming to Cogan syndrome, here we can see aortitis and aortic insufficiency similar to Takayasu. So in this, we can see right brachiocephalic, left common carotid, and left subclavian artery stenosis at their origin. Also, we can see celiac and SMA artery stenosis and aortic stenosis here. This is a case showing pulmonary aneurysm. This is a case of Behçet disease, which is in which we can see pulmonary artery aneurysms, superior vena cava thrombosis, and mosaic perfluent. Ground glass opacity due to hemorrhage and consolidation can also be seen. In this case, we saw a left-sided pulmonary aneurysm, which was treated. Further, after 6 months, right-sided aneurysm developed. Then this is a case of Hughes-Tobin syndrome, which is a variant of Behçet's disease. Here we can see multiple pulmonary aneurysms, and it can be distinguished on Behçet's by absence of mucocutaneous findings. Coming to medium-sized vessel vasculitis, first is the PAN. So PAN is a necrotizing vasculitis. Involvement of arterioles, venules, capillaries, and kidneys are absent, which indicate MPA. That is the distinguishing point from the MPA, microscopic polyangiitis. Here we can see patchy ground glass opacities due to pulmonary hemorrhage, and which were cleared after immunosuppressive therapy. Coming to Kawasaki disease, involves the coronary arteries, causing aneurysm, ectasia, premature atherosclerosis, and stenosis. Typical appearance is braid-like coronary arteries. Here we can see involvement of the coronary arteries with aneurysm, stenosis, and plaque formation. Coming to small vessel vasculitis, first is ANCA-related vasculitis. ANCA is anti-neutrophil cytoplasmic autoantibody. So it can be cytoplasmic or C-ANCA, or perinuclear or P-ANCA. Wegener's is associated with C-ANCA. Churg-Strauss is associated with P-ANCA, and MPA can be associated with any of these. So this is a pathophysiology of Wegener's showing necrosis and abscess formation following inflammation. Then on chest radiographs and CT scans, we can see multiple cavitary masses as seen in here, which are generally bilateral, and cavities become thin-walled with treatment. So these are thick-walled cavities which can be seen. Lung consolidation can occur due to hemorrhage. Tracheobronchial involvement can also occur. Then it is then coming to Churg-Strauss or eosinophilic granulomatosis with polyangiitis. This is the pathophysiology as seen here. Eosinophilic infiltrates are seen infiltrating the arteries, causing plaque formation and necrosis and inflammation. So features are similar to Wegener's, and we can see 3 phases: allergic, eosinophilic phase, and systemic phase. Here we can see involvement of pericardium and pleura. Here there are small consolidations, and we can also see some necrotizing opacities. Coming to MPA, this is also a small vessel vasculitis, generally associated with P-ANCA. C-ANCA can also be seen. The radiographic features are pulmonary hemorrhage, pleural effusion, pulmonary edema, and however, progression to fibrosis is rare. Here we can see diffuse pulmonary hemorrhage, ground glass opacities in this case of microscopic polyangiitis. Coming to diffuse alveolar hemorrhage, the radiographic features are similar on CT and radiographs, that is diffuse ground glass opacities and interlobular septal thickening. Ill-defined nodules are also seen, and chest radiographs may be sometimes not. What are the causes? So these can be divided to with pathologic capillaritis and without pathologic capillaritis. With pathologic capillaritis are, as we have mostly discussed, Wegener, CSS, microscopic polyangiitis, good pasture we'll discuss, and Knox-Churning in particular. This is a case of SLE showing diffuse alveolar hemorrhage in this case, and this is a second case showing pleural effusions. This is a case of HSP showing diffuse hemorrhage, and the patient came with hemoptysis, and it is cleared on further CT after treatment. This is a case of essential cryoglobulinemia with diffuse alveolar hemorrhage. Then these are without pathologic capillaritis, including coagulopathies, inhalation injury, good pasture, SLE. This is a case of good pasture showing diffuse alveolar hemorrhage in the form of ground glass opacities and septal thickening. And this is the involvement of kidney on this ultrasound. This is a rare case of idiopathic pulmonary hemosiderosis presenting with a diffuse alveolar hemorrhage. In the end, I would like to say that the diagnosis of vasculitis is often delayed as they have non-specific signs and overlap of symptoms. Integrated clinical and radiological and pathological approach is valuable for early diagnosis, and MD-CT is of prime importance for proper diagnostic use. Thank you very much for your patient listening.
Good evening. Thank you very much for asking me to be a part of this lovely meeting today. It's a great pleasure to interact with all the experts in the field from pulmonology. So my presentation today is basically a little bit about pulmonary vasculitis from a rheumatology perspective or a rheumatologist's perspective. As we know, vasculitis, the phenotype is based on the vessel size that is affected, whether it's large vessel, medium vessel, or small vessel. The typical example for a large vessel vasculitis is Takayasu's, and the typical example for a small vessel vasculitis is ANCA-associated vasculitis. But then there are many other vasculitis, vasculitides, which also are there, which may not have a classification, which could also affect the lung. And some of them affect the parenchyma, some of them could be the vasculature. Takayasu and typically the Behçet syndrome are known to affect pulmonary vasculature more than the parenchyma. The others are known to affect the parenchyma more than the vasculature. Lung involvement is a bit rare in medium vessel vasculitis, but for ease of discussion, because of time constraints, I will restrict myself to some discussion on ANCA-associated vasculitis. And the three classical phenotypes in ANCA-associated vasculitis is GPA, what was previously called as Wegener's, microscopic polyangiitis, EGPA, or what was called as Church-Strauss in the past. It is well known that most of these vasculitides are multi-system diseases, and pulmonary manifestation is just one of them. So the previous speakers have already alluded about the radiology, clinical aspects, and other things. So from a practical point of view, I'll just go through a few evaluation tips. Now, one of the most important evaluation tip that I'd like to cover is about meticulous history and physical examination for other organ involvement, careful interpretation of autoantibody tests, the importance of tissue diagnosis or a biopsy, and looking for other possible causes. So this is going to be the overview of my presentation. The skin is the window for any vasculitis. So when you have a patient with suspected pulmonary vasculitis, be very careful to examine the skin, because on the skin, there could be subtle clues like what I have shown here, which are splinter hemorrhages, or more evident clues like this, which are palpable purpurae like these two, or very bad ischemic changes like digital gangrene or non-healing ulcers or vasculitic ulcers. Sometimes you could find these small lesions like this. These are dermal infarcts. So the skin is the eye opener for many a vasculitides, and in itself proves that there is another system that is involved. A very careful history for all other systems should be taken in any patient with suspected pulmonary vasculitis. And one other organ that can be easily missed is the neuropathy. Neuropathy can be in variety of ways, but the commonest presentation is that of a mononeuritis multiplex. You could maybe not miss something as gross as this, which is bilateral foot drop or a wrist drop like this. But many a times, subtle neuropathies can be easily missed, like this one with an ulnar neuropathy here. This was one of my patients with cryoglobulinemic vasculitis, or this one with rheumatoid vasculitis with a foot drop on one side. You can see the difference in dorsiflexion of the foot on the both sides. Certain other manifestations which are silent and which should be sought of would be GI. This is one of my patients with EGPA or Shirk-Strauss who presented with a GI bleed. The initial hemoglobin of 10 did not give us a clue, but when she had a massive bleed and dropped a hemoglobin, our eyes opened. Renal is one system which could be very silent, so one has to be extra vigilant. And the only manifestation in the renal could be urinary abnormalities, because by the time the creatinine is raised, we know a lot of renal volume is lost. So any urine examination, good urine examination with more than 10 RBCs per high power field or a proteinuria of more than 500 milligrams per day should alert us to look for renal vasculitis. Eye is another area that has to be very carefully looked for. Many a times we don't look at the fundus. This is a classical retinal vasculitis in a lupus patient. But however, sometimes it could be like this, a red eye, which is diffuse scleritis, but sometimes it could be very bad like this, which is a necrotic scleritis. And both of these were patients with GPA or Wegener's. Sometimes the eye involvement could be subtle, and unless a careful clinical examination is done, you are likely to miss. This is one patient with a proptosis. You can see the eyes between the two sides, and this was due to a retroorbital mass. So subtle clinical signs are very important to pick up. ENT is another one. Recurrent sinusitis, recurrent glue ear, recurrent otitis, deafness are some of the things that have to be elicited. And very interesting in this patient with GPA, once again, you can see that she has a hearing aid. And this was because of previous multiple glue ear and sensory neural hearing loss. But one other important clinical sign in this other ear is the presence of perichondritis. So this is a patient with GPA who had perichondritis. And this lady had previous history of recurrent nasal obstruction and crusting, and you can make out that she has a collapsed bridge of the nose. So all these histories have to be elicited. Many a times patients learn to live with these subtle symptoms, and it's up to the clinician to elicit these histories so that we can pick up a clinical diagnosis. Likewise, this lady who actually came for a pulmonary presentation with a cavitating lesion in the lung, in fact, on detailed examination, had repeated ENT consultations, repeated ENT surgeries, and you can make out a collapsed bridge of the nose and a hole in the inner canthus. That is because of destruction of the sinuses, and you can see the same thing radiologically. On careful evaluation, she had a history of stridor, and you can see that she had bilateral bronchial stenosis, more on the right side, which had to be stented later on. So pulmonary manifestations obviously has been discussed earlier, but there are a variety of ways, starting from consolidations to cavities to pulmonary vasculitis presenting as diffuse opacities, to some of the emergencies like this, where the patient had to be intubated straight on his visit to the casualty. And this was a case of Wegener's, who had renal involvement in the form of crescentic glomerulonephritis. And that's his bronchoscopy showing blood in the airways. And that's his lung biopsy, as well as the pearl staining, which was positive for hemosiderin-laden macrophages. And this was a classical case of DAH, or diffuse alveolar hemorrhage. So this patient had a pulmonary renal syndrome. So in these patients, whenever they're not, forthright in coming up with other systemic involvement, the bottom line is to very carefully evaluate all the systems to look for involvement in other systems. So one of the important things that people use, especially in these group of vasculitides, is to look for ANCA. It's important to understand that ANCA is measured by two different methodologies. One is the immunofluorescence and the other one is the enzyme immunoassay. The immunofluorescence shows either a C ANCA or a cytoplasmic or a P ANCA or a perinuclear pattern, but it is important to remember that the immunofluorescence has less sensitivity because it is observer dependent. So hence immunofluorescence has substantially lower predictive values than a positive ANCA determined by enzyme immunoassay. So when you ask for an ANCA, you can ask for an enzyme immunoassay, and if either PR3 or MPO is significantly positive, you can also ask for an ANCA by immunofluorescence to compare. This is how ANCA looks on immunofluorescence. That's the cytoplasmic pattern and the perinuclear pattern. And cytoplasmic pattern is more described with GPA or Wegener's, and a P ANCA is more described with MPA and sometimes with Church-Strauss. But it's important to remember that only about 45 to 50% of patients with Church-Strauss are ANCA positive, and in majority of the instances, it is P ANCA. So obviously, an ANCA negativity does not exclude GPA. It's also important to understand that a lot of patients with limited disease or localized disease to one organ can be ANCA negative. And it can also be negative in diffuse disease in roughly about 20% of the patients. But when it is positive in the right clinical scenario, the specificity is more than 90%. However, the most important aspect in vasculitis is a tissue diagnosis where we can. I know pulmonologists are very forthcoming when it comes to bronchoscopies and biopsies, but there may be many instances where the lung lesions are deeply placed, or you may not be able to take a biopsy, whether it's bronchoscopically or CT guided, or the patient is too sick, when you have to look at other organs. And these are some examples of other organs. Why is it important to have a tissue diagnosis? For the simple reason that you're giving a diagnosis for a lifetime for this patient, and therapy involves long-term medications. And this is a classical example of renal biopsy showing precentric glomerulonephritis in a patient with GPA. This is a bowel biopsy showing eosinophilic cryptitis in a patient with EGPA or Church-Strauss. And this is an ENT biopsy showing necrotizing vasculitis. So you'll have to start looking at various organs. If lung is not possible to see, where else you could get a histological diagnosis. And why is it important? If you look at the diagnostic yield, when you look at the various sites from where a biopsy can be taken, the kidney has the best diagnostic yield. A transbronchial CT-guided biopsy has only a diagnostic yield of 50% and ENT still less. And it is important when you take a biopsy that the biopsy should be more than 5 millimeter at the edge of the lesion and not directly from the lesion. Because if you take a biopsy from a necrotic area, all you might get is just inflammatory cells and nothing else, and it may not be diagnostic. And so also many other organs which are not so useful for a biopsy, but when present, it is very suggestive. Sometimes clinical manifestations from vasculitis may be so diverse, and infection becomes a critical differential diagnosis. And lung is obviously one such area where infection is a very critical exclusion. Likewise, this is an unusual case of brain where the patient had pachymeningitis. And in a patient with pachymeningitis, obviously infective causes like tuberculosis or malignancy and other things have to be excluded. And a dural biopsy was taken, meningeal biopsy was taken, which showed vasculitis. So sometimes it's very important to, even if the site is difficult to access, to try to push for a biopsy, because without that, many a times vasculitis cannot be diagnosed. There are many conditions that mimic vasculitis, and infection is one such thing. And infection and vasculitis have a different type of connections. Infections have certain clinical features which are similar to vasculitis. Like, for example, hepatitis B can present like polyarteritis nodosa. Hepatitis C can present as cryoglobulinemic vasculitis, or HIV is a great mimic of everything, or infective endocarditis can present with vasculitic lesions. There are certain histological features that mimic vasculitis, so you have to be careful. For example, you have Aspergillus or Mucor, both are angio-invasive fungi, and if proper fungal stains are not done on a histological specimen, the diagnosis can be missed, and you might just see vasculitis even on this specimen. And ANCA is not the only test to go for to make a diagnosis, because ANCA positivity is well described in various infections like endocarditis, tuberculosis, HIV, and others. Malignancy is a great mimic of vasculitis. And there are many other conditions which may not be vasculitis, like sarcoid and various other diseases. So it's very important to make sure that a diagnosis is confirmed, because therapy involves a lot of toxic medications and one has to be 100% sure. For the want of time, I'm not covering various other diseases like lupus, APLA, Sjogren's, and many others which can cause pulmonary vasculitis. Just a quick word about modern therapy for ANCA vasculitis. We have an induction phase which goes anywhere between 3 to 6 months, which is important to control the aggressive inflammation. Then we have a maintenance phase that is important to go for to prevent flares. And then there is a long-term follow-up. It is important that these diseases are ones where people frequently relapse. So when a patient flares up, we'll have to re-induce the patient, whether the flare is in the same organ or a different organ. The modern treatment of vasculitis involves remission induction, and 2 drugs are used, either rituximab or cyclophosphamide. If the patient is acutely unwell with a rapidly progressive glomerulonephritis with or without alveolar hemorrhage, there is some role for plasma exchange. And then after the induction phase, we have maintenance phase. And the best drug for maintenance today is rituximab, given every 6 months. Or where possible, where not possible for clinical reasons or cost reasons, azathioprine is the next best thing to be used. Glucocorticoids form a very important part of treatment of vasculitis. Steroid-sparing complement receptor inhibitors have now been shown to be effective in vasculitis. This is called avacopan. It is still not available in India. So with this, I finish my presentation, and a lot of things can be discussed over the panel discussion. Thank you very much.
So, thank you, panelists. From the talk that I can infer, I would like to just conclude by saying that a wide range of disorders cause pulmonary vasculitis. Presentations may range from insidious onset through to a catastrophic, life-threatening alveolar hemorrhage. Precise diagnosis is frequently challenging, even when a biopsy is possible by a pulmonologist. Careful clinical evaluation is critical, and it is important to exclude infection, which we heard from Dr. Ramesh's talk. Treatment is dictated by the severity of the presentation and extent of the organ involvement. It mostly involves the induction phase as well as the maintenance phase. And without treatment, pulmonary vasculitis is almost universally fatal. With this, we would start with a panel discussion. And I would basically think of starting with a case presentation, which I would present. And then we would take the discussion from then on. Is my screen visible to all of you?
Yes.
All right. So we'll discuss one case, and this would probably be an interdisciplinary discussion since we have a radiologist and a rheumatologist on board. So this is a guy who's breathless at presentation, no focal signs, scattered crackles only. He doesn't have any cardiac abnormalities. Saturation is 91 at rest. On arrival, PO2 is 60 mmHg, PCO2 of 27, mark widening of the AA oxygen gradient. WBC is 16,000 with 84% neutrophilia, and HB is 13.1. And this is the X-ray. Dr. Nikhil, can I have your comment on this, please?
Good evening, ma'am. This is a chest radiograph of the above said patient, and this shows multiple ground glass opacities scattered throughout both the lung fields. Also, it has a tracheostomy tube and a central venous line in situ, so the patient must be very sick. There is no specific pattern of these opacities which are seen in the lung fields. So these are diffuse pulmonary infiltrates.
Would you like to give differentials on this? This patient is admitted in the ICU, intubated and on ventilator.
One may be infective, like bronchopneumonia.
Sure.
And the other may be Fluid overload, it is definitely not, because the reverse battering appearance is not there. So diffuse pulmonary hemorrhage may be another. And ILD may be another.
All right. So when we just, and this is the CT scan, sir. Would you like to throw a highlight on this?
So this CT scan.
Sorry, I don't have a video. So I have put in the one picture of this, which is a lower lobes.
The CT here, the CT section shown here shows diffuse ground glass opacity in bilateral in the visualized lung field. So also there are a few spared areas as seen here, and some interlobular septal thickening as seen here and here. So this may be a diffuse pulmonary edema or diffuse pulmonary hemorrhage.
So from the X-ray to CT scan, we have narrowed down our differentials to a pulmonary edema as well as an hemorrhage. So can this be an ARDS as well?
Doesn't look like that, because it does not have those specific consolidations like pictures.
We used to see something like this during COVID and H1N1 epidemics as well, sir.
That is like the opacities are not like that. Those are peripheral opacities. This is a diffuse generalized type of ground glassing.
So we, zeroed down to this thing. We zeroed down to pulmonary edema, infection, ARDS, and diffuse alveolar hemorrhage. Going further, how would you investigate? So, Dr. Naeem, would you like to just throw a light on this, please?
Yeah, so in this case, given the clinical scenario and the radiological background, we will go with the lab testing to rule out infection like WBC count, CRP in these cases. And once we can go for blood cultures as well as urine routine examination if we are thinking of diffuse alveolar hemorrhage. So we may have red cell casts and deranged kidney function test in these cases might be prevalent by raised creatinine and BUN levels. So gross basic investigation would lead us to a next step in this case.
So would you add this into your armamentarium? Surgical lung biopsy, autoimmune serology, renal biopsy, a bronchoalveolar lavage, and a pulmonary function test. Of course, not possible because the patient is in the ICU.
Not possible in this test.
Yes.
The other things mentioned here, like bronchoalveolar lavage, renal biopsy, and autoimmune testing. Yes, but we should have a baseline first to see about the platelet count, CRP, which way we are going. Then we have to prioritize our next armor. So with this clinical picture going towards diffuse alveolar hemorrhage, bronchoalveolar lavage will be my next choice, followed by the autoimmune serology at the same time.
All right, sir. So to give you the answer, the ECG echocardiogram was normal. The renal function tests were normal. The urine microscopy was completely normal. HB was inconclusive. I said it was 13. It was not fit for measurement of the pulmonary function tests. So the key test over here is bronchoscopy, right? So bronchoscopy would help us in taking out the ball. Here, I would like to add one thing. When you do a bronchoalveolar lavage, and if there is an alveolar hemorrhage, serial collections of the lavage will be more bloodier. And
Absolutely.
then when you send it for hemocytin-laden macrophages, that would turn out to be positive. If the serial lavages are not bloodier, it would probably be a bronchial bleed. But if the serial lavages are bloodier, it would probably be an alveolar bleed. So we did a bronchoscopy, which was performed in the ICU when the patient was intubated, blood sent through the endotracheal tube. Microbiological investigations, of course, as you rightly said, were all negative. So all the cultures were sterile. So what do you do next? Vamsi, are you there?
Yes, madam, I'm there. Yeah.
Yeah, Vamsi, what would you do now?
Because the microbiological investigations are negative, so we can conveniently and comfortably rule out infection in the first place. Because the bronchoalveolar bronchoscopy has revealed blood, there's a possibility that it is a hemorrhage. So probably we'll have to go for more specific tests like the ANCAs and all, if they haven't already been done. And even if they are negative, probably it is the right time to contemplate diffuse alveolar hemorrhage in this case. And the most common being granulomatosis with polyangiitis, probably we'll have to go ahead with empirical treatment, because this is a case with an acute organ threatening manifestation wherein there is a respiratory failure.
Okay, I'll come to that. Okay. So we, of course, thought that this is a diffuse alveolar hemorrhage. So this is basically a disorder with or without a pulmonary capillaritis. And these are the differentials that we probably kept it. It is a Goodpasture syndrome or an ANCA-associated vasculitis, immune complex disease, secondary vasculitis, that is SLE, or HSP, antiphospholipid syndrome, or a mixed cryoglobulinemia, Behçet's, idiopathic pulmonary hemosiderosis, coagulopathy, or drug or chemicals. In this case, eventually, as Dr. Naeem and Vamsi said, asked for, anti-GBM antibodies were negative. ANCA was negative over here. So I would like to ask Dr. Ramesh, how frequently do you see when you have a patient where you're suspecting, capillaritis or a vasculitis, where you get ANCA negative and you are lost in a critical care? Dr. Ramesh?
Yeah. So one of the important things, I wanted to know one point, madam, how old is this patient?
Well, this patient was around 42 years of age.
Okay. So one of the important things in immunology is where is the test done and what is the methodology used.
Sure.
Because we don't have standardization in a lot of labs, a lot of non-NABH accredited labs do these tests. One of the biggest problems is over-relying on autoantibodies to make a diagnosis. So it depends on in what way, because if you depend only on immunofluorescence to do an ANCA test, then the question comes, how good is the observer in doing an immunofluorescence? If you're from a center which is experienced in doing ANCA tests, then your pickup rate is going to be high. So when it comes to the autoantibodies, if the ANCA is done in both the methods, that is immunofluorescence and ELISA, for discussion's sake, I would assume that it has been done in both the methods. Both are negative. That is, in one way, says that less likely to be ANCA-associated vasculitis. But, however, we know that about 30% of patients with ANCA-associated vasculitis can be negative for ANCA at the time of presentation or anywhere during their course of illness.
Sure.
When you showed me the whole list of immunological diseases, for the ease of our understanding, I would concentrate only on 3 important conditions that would cause this type of a presentation. One is ANCA-associated vasculitis, anti-GBM disease, lupus, and antiphospholipid antibody syndrome.
Yeah.
All other immunological diseases are extremely rare to cause a diffuse alveolar hemorrhage, and you don't have serological markers for most of them. So if you've done a proper ANA immunofluorescence and a proper methodology of ANCA and a GBM, then the autoantibodies are negative. But as you rightly said, this could still be any one of the diseases which are antibody negative. Less likely to be lupus because it's extremely rare to find an ANA negative lupus. So more likely, I would put my money on an ANCA-associated vasculitis where the antibodies are negative for now.
Sure. All right. So all these results took some time and the patient was deteriorating. So can I have Dr. Dinesh, what would you do now, sir? Dr. Dinesh, are you there on board?
Yeah.
Yes.
So right now I would start treating first of all, I would start treating the hemoptysis or the thing by giving the steroids and so on and so forth, because anyway it is not infective. So I would straight away start the steroid therapy, pulse therapy, and then go on to give either rituximab or any other thing, but I would go with the rituximab, ma'am.
Dr. Dinesh, would you contemplate doing biopsy?
If the patient is intubated, yes, I would go ahead and do it if it is possible. If there is not much of a bloody thing there, Otherwise, I would still wait, first give a thing, and then go ahead with the biopsy.
All right. So I would like to ask to Dr. Ramesh again. So how would you manage this case? I mean, would you rely on the biopsy, or you would straight away treat this patient with either a rituximab or maybe induction for the remissions, either a cyclophosphamide or whatever?
Sure, madam. So since there are no extra pulmonary manifestation, we can't rely on doing anything else, although we assume now that somebody would have taken a very careful history of all the extrapulmonary organs and looked meticulously for it. The lung, we have already demonstrated diffuse alveolar hemorrhage, so a surgical biopsy is not going to add up to the diagnosis. It only is going to show that there was a hemorrhage, that's all. So as you have rightly said, the treatment goes on. So the first aspect is a methylprednisolone. Coming to the choice of therapy, whether it is cyclophosphamide or antiphospholipid antibody, or rituximab.
Rituximab, yeah.
The important thing to understand is rituximab is slow to work. Rituximab takes at least good for 2 weeks to work. So the drug that works immediately for you, at least within the next 10 days, is cyclophosphamide. So my choice here would be IV methylprednisolone and cyclophosphamide. This would be my choice of therapy as of now.
Thank you, sir. You've taken my word. So what we did was we had an MDD. We had a discussion with our rheumatologist as well. We didn't go for the biopsy, as you rightly said. It would have just given us again the hemorrhage, which the lavage had already given the answer to us. So we started the patient on an empirical therapy with IV cyclophosphamide and IV methylprednisolone. The patient had a good short-term response immediately. But my question to you is, Dr. Ramesh, is this really rational? In the ICU, we are really, stuck up what to do. We are supposed to give answers to the relatives. The patient is young. Patient has alveolar hemorrhage. We are not able to give a diagnosis. But, since the cultures were sterile, of course, we are not sure whether the answer to that microbiological analysis is also correct or not. Are we really rational in giving this to the patient?
Completely. Here, this is life-saving therapy, what you're doing to your patient. When you have ruled out infection completely, you have excluded infection as a cause for the presentation, I think you're left with no choice. And these form of treatments are very important and have to be done quickly, considering that even with the best type of treatment, whether it is steroid, cyclophosphamide, rituximab, plus minus plasmapheresis, still the eventual outcome or mortality is very high in alveolar hemorrhage. So no time to be wasted. I would convince the patient.
So to add to what you have said, this is a study from a Mayo Clinic, which normally says that when you don't have anything, the relative prevalences of granulomatosis with polyangiitis is 32%, Goodpasture is 12%, collagen vascular disease is 12%, other immune complex disorders is 12%, IPH is 6%, and unclassified pulmonary renal syndromes are 26%. So looking to that 32% window of granulomatosis with polyangiitis, we thought of giving a life-saving IV cyclophosphamide and methylprednisolone to the patient. So, this was our, pre-test probability and also a diagnosis that micropolyangiitis and granulomatosis with polyangiitis is a predominant one in this patient. But can we trust clinical presentations to pick up these entities, Dr. Dinesh?
First and foremost, as the speakers have alluded, we need to go in through the history and clinical examination. Yes, not all the time can we really rely on the biopsies, or because as you rightly said, if there is a lot of blood in there, we can't be doing it. So, but if it is done, it will definitely give us a definitive answer. If not, I think we should go in with the clinical history and the symptoms. So lung is one thing, but the other easily biopsiable one is the kidneys. So if at all there are any signs and symptoms of the kidneys, maybe we can do that.
Otherwise, so it was completely normal with the serum create normal, urine sediments negative, urine routine micro was negative. Patient had a good urine output. There was no reason why that we would probably biopsy a kidney.
That's what. If there are no symptoms, then
there's no symptoms whatsoever. Yeah.
So then we are left with no other option but to rely on our signs and symptoms and clinical discretion.
So, this is what we, concluded, that this is basically a diffuse alveolar hemorrhage and granulomatosis with polyangiitis. Dr. Ramesh, you can correct me if I'm wrong, because this was just our, we were in a dire emergency, a patient was very critical, and this is how we did our MDD and came to. So there are ample anecdotal evidence of, the later development of this classical features and just occasionally a later development of typical serology. And therefore, given the high mortality of granulomatosis with polyangiitis and our inability to exclude it, we need to treat as for now as granulomatosis with polyangiitis.
So from the giving it a label for, our diagnostic purposes, I would just call this as undifferentiated vasculitis with diffuse alveolar hemorrhage.
Sure. I agree with you. So in this case, the patient was weaned from the ventilator over the next week. There was a complete suppression of the disease process. No hard evidence of a true vasculitis. Repeat dose of IV cyclo and introduction of azathioprine was done. And maintenance of prednisone 20 milligram and azathioprine daily. So again, to the panelists, what is the diagnosis here?
So as I said, I would label this as unclassified vasculitis. You have to understand that if this is GPA, within the next few years, the risk of relapses is very high. You are giving azathioprine as the maintenance drug. And when you look at maintenance regimens for vasculitis, the risk of relapse is higher in azathioprine treated patients compared to rituximab treated patients. So invariably, these patients might relapse in the same organ or some other organ over a period of time. So hence, a careful clinical examination during every outpatient visit is important. But it is important, given that this patient has come out of a life-threatening situation, that he is maintained on long-term immunosuppression under the joint care of pulmonologist and a rheumatologist.
Thank you very much. So let's start with the panel discussion now. All right then. So my question to Dr. Naeem there is, Dr. Naeem, are you there?
Yeah, I'm here only.
Yeah, all right. Okay, sir. So what are the clinical clues? What clues that you look for to the diagnosis of pulmonary vasculitis?
See, if we come on to the clinical clues for a diagnostic purpose, we have a huge overlap of signs and symptoms which rarely point us towards a clear-cut diagnosis. So, as already told by my colleague here, that history and examination, along with the collaboration of lab, will guide us, help us to reach to a diagnosis. So, what's important in history? What clues we get from the history? An unexplained fever, unexplained weight loss, the nasal crusting or the epistaxis, foot drop, wrist drop, as shown by the pictorial presentation, hematuria, hemoptysis, claudication, and a history of hepatitis guides us towards some clinical clues. And what we see in the examination part, the sensorineural hearing loss is there, neuropathy is there, we see a nasal bridge destruction there, and there are discrepancies in the blood pressure or bruit. So these are the some clinical, historical and examination point which guide us towards a clinical scenario. And what specifically, when there is an organ specific involvement, we have to weigh them in association with clinical history, like a palpable purpura, mononeuritis multiplex, and unexplained ischemic events. We can see glomerulonephritis, like in DHE, we have hemoptysis. So these are some clinical clues which guide us towards the vasculitis process which might be going on, whether in the lungs or there may be a systemic involvement.
Yeah, so that's very crisp. I think a good history taking and a good systemic examination will probably give you some clue how to proceed for that particular patient. So let's go to Dr. Dinesh. Dr. Dinesh. So we all know that we face a lot of challenges as far as when we consider diagnosing pulmonary vasculitis. So what are these diagnostic challenges when we need to diagnose pulmonary vasculitis?
Like have you seen in your case and multiple cases, we always face this. It's really a challenging thing since the diagnosis of vasculitis is definitely a challenge. It's a significant overlap in clinical, radiological, and lab features with multiple disease processes. Particularly infection and drug reactions, which are there commonly seen. Like in the in the oncology department, we definitely see a lot of DAH. Especially after bone marrow transplant and all that stuff. So as a result, it is often a delay in establishing the diagnosis of vasculitis, but we should be quick to react to at least the signs and symptoms and try to extract a good clinical data or the history from the patients. Once a diagnosis is made, as you know, the immunosuppressive therapy and so on and so on. But signs and symptoms of vasculitis can overlap significantly with other conditions, including infections, malignancy, connective tissue disorders, drug toxicity, venous thromboembolism. So DAH is a myriad etiologies, and with the pulmonary capillarities suggestive of vasculitis must be differentiated from diffuse alveolar damage and bland hemorrhage like coagulopathy, mitral stenosis, and so on, and including drug-associated diseases. So it really boils down to, of course, antibodies. But when applied at risk population, ANCA has a sensitivity, as Dr. Ramesh has already told about the ANCA, what the sensitivity and specificity is. So, the sensitivity diseases is often, overlooked. But yes, we need to see it. Like, in sensitivity, it is just about 85 to 90%, and specificity about maybe 90-95% in active systemic GPAs. In organ-limited disease, the sensitivity decreases, up to even Dr. Ramesh said, even in the disease process, even
so
after
that will come to the specificity and sensitivity of the diseases. It's basically a overlapping features of the clinical, radiological, and the laboratory features, which probably causes the diagnostic challenges. So let me come to Dr. Vamsi. Vamsi. So.
Yes, madam.
Could you just allude on the extrapulmonary, rather the other systemic manifestation of vasculitis?
Yeah, I think Dr. Naeem has already, covered most of the extrapulmonary symptoms and signs. But when it comes to systemic involvement per se, the most common system probably is the skin, that is the cutaneous system, where it gives us the maximum clues. And because enough has been described, already discussed about skin, there is just one point that all purpura need not be vasculitis necessarily, and probably we will have to see it along with the constellation of other symptoms and findings in the lung and other systemic features. And after the cutaneous thing, then we can sometimes in vasculitis like EGPA, that is the Church-Strauss syndrome, cardiac involvement is commonly described, and it is also described as the most common cause of mortality in EGPA. So probably if a patient is coincidentally also having some cardiac issues like cardiac defects, conduction defects, or some kind of rhythm disturbances or myopathy and all these things, cardiomyopathy and all, then probably we have to contemplate EGPA. And then we have other systems like the most important, the renal system. If the patient is having, it has already been discussed, I don't want to waste time on that, but the urinary sediment is probably the most important sample you're collecting in any patient in whom we are suspecting vasculitis. And the urinary sediment, the proper urinary sample is a reflection of renal biopsy. And if you can interpret it properly, then probably we can as well avoid renal biopsy in some cases. And sometimes the renal system manifestations might not be evident clinically, but probably urine sample might give us a clue whether something is brewing up in the kidney and might show up later in the clinical course of the disease. So essentially the cutaneous, the cardiac, the renal, and the other most important, and this thing is the musculoskeletal, that is the arthritis. So if the patient has history of arthritis, then the patient might also have CTD-related vasculitis, which is not uncommon, and any history of arthritis, or if patient is having muscular problems like there can be polymyositis, dermatomyositis, which can also cause features of vasculitis, and sometimes as well as alveolar hemorrhage in the lungs.
So that's fantastic. So the skin, the kidneys, the cardiac systems, and the gastroenterological system. That's great. Let's go to Dr. Dinesh again. Dr. Dinesh, when would you suspect EGPA in a difficult to treat asthma patients?
That's a very tough question, but definitely an important one. As we know, asthma is the major feature of the EGPA, usually preceding the symptoms of vasculitis. And it's usually characterized by distinct features of asthma patients in a general population. Firstly, it is usually late onset asthma, which begins basically in adulthood, usually. And secondly, the allergic background is present is less than one third of the patients with EGPA compared to approximately 70% of the patients with asthma in general. And there are no seasonal exaggerations, which we usually see. Atopy, if present, is associated with a better prognosis, but with more severe or uncontrolled asthma manifestations in the year before the development, or year or so before the development of vasculitis. Thirdly, the asthma in EGPA is usually severe and often requires long-term treatment with oral corticosteroids. Despite the regression of systemic disease, it remains unclear why the systemic therapy controls the systemic manifestations in EGPA, but not asthma symptoms. So some authors even speculate some dissociation between eosinophilic bone marrow production and eosinophilic recruitments in the airway, which results in that in the sputum, but not in the blood. But eosinophilia is still present in EGPA patients in remission phase. I think Dr. Ramesh will all agree to that. Asthma, although often severe, may paradoxically improve during the full-blown vasculitic phase. Recently, it is demonstrated that severity of asthma increases 3 to 6 months before the onset. As I said earlier, maybe 3 to 6 months or a year before the onset of systemic symptoms. Finally, you can also say that EGPA is often accompanied with allergic manifestations like in the upper respiratory tract and chronic sinusitis, nasal polyps, like all the other speakers have spoken. And it's really challenging, especially in biopsy, to both typical and histological features of eosinophilic polyposis are if it is present. So lesions observed in GPA, such as destructive granulomatous inflammation or nasal crustings, are uncommon in EGPA. But however, secretive otitis media, chronic ear damage, or sensorineural hearing loss, or facial nerve palsies may also occur, like what others have told. A small proportion may also experience the DH, like in your case and some cases which I've seen as well.
So you have you have just a simple difficult to treat asthma with eosinophilia, right? And so Dr. Ramesh, I also like to invite you to answer this question. The positivity of ANCA in such patients is, around 30 to 40 or maybe 50%. And, there's a persistent eosinophilia. Even if you do a lavage, you just have an eosinophilic lavage. And patient is not controlling, is completely on steroids. So what are the points? What are the clues which will probably direct you that this patient has EGPA?
So we have to understand that EGPA has two components. One is the allergic component. The other is the vasculitic component. ANCA positivity is only seen in the vasculitic presentations. So for an EGPA patient who has purely allergic component, for example, the allergic components include asthma, nasal polyposis, and even GI, like for example, eosinophilic gastroenteritis. These people are always ANCA negative. So a diagnosis of EGPA can be easily missed. If you have vasculitic manifestations, which is mainly in the form of neuropathies, cardiac, renal, then you can expect an ANCA positivity. But even here, in those with vasculitic manifestation, it is positive only in 30 to 40% of patients with vasculitis. And the pattern is predominantly P-ANCA positivity. So these are the two important aspects we have to remember. So many a times you might have to rely only on your clinical clues in EGPA. One of the commonest, if you see somebody with a difficult to treat asthma with a mononeuritis multiplex, difficult to treat asthma with a purpura, then your head should start thinking more in terms of an EGPA rather than only a difficult to treat asthma.
it's more of a clinical acumen rather than, the investigative modality when you just look at the allergic point of view rather than the vasculitic component. That's what I understand, right, Dr. Ramesh?
Yes, yes.
Thank you so much. Yeah. So I would like to ask you this. What is the specificity and sensitivity of ANCA? Especially, as I said, EGPA, the vasculitic component, even if it is vasculitic, this, turning out to be positive is just 30 to 50%. So how do you, interpret this specificity and sensitivity of ANCA?
So more than going by numbers, what I would tell you a few things are, one, in the right clinical context, if you have an ANCA positivity, your specificity is more than 90%.
Okay.
You have to understand that there are a lot of false positives for ANCA. Infections are a big headache. One of the clues for that is infections cause an immunofluorescence positivity. Very rarely do they cause PR3 to go up or an MPO to go up. Okay, so one clinical clue for us is when you see only an immunofluorescence pattern of ANCA with a negative PR3 or a negative MPO, always think whether this is a false positive ANCA and whether you're looking at an infection. The third important aspect about ANCA is that if you have a very strong positive ANA, say for example, you have a patient with a very strong positive ANA, you have also requested an ANCA test in this patient, and the ANCA is done by ethanol fixation of the neutrophils. Due to this anomaly, in a patient with a very strong positive ANA, you can get a false positive P-ANCA pattern. So some of the labs will give P-ANCA positive, or they might call it as an atypical ANCA positive. And this is actually a positive ANA which has been wrongly misinterpreted because it is an ethanol fixation. The way to exclude this would be when you do the PR3 or the MPO and you find that they're both negative. Very rare instances where you have patients who have everything positive. You have a P-ANCA positive, you have a C-ANCA positive, and rarely you come across all these weird lab reports. Yeah. When you see both types of ANCA positivity, which is extremely unusual in a vasculitic disease, always think of drug-induced vasculitis. There are few drugs which can cause vasculitis, especially cocaine inhalers and things like that. So drug-induced vasculitis can cause weird ANCA positivity, and in many instances, and HIV is one condition where a lot of antibodies can be positive. So whenever you see, the clinical pattern not fitting and you find multiple antibody positive, just go back to your file and check, make sure you've done your HIV test.
Okay. So please stay on the board. This question is again for you. So what's the role of other immunological testing, like, rheumatoid factors, ANA, myositis panel, anti-GBM antibodies, immunocomplexes, when you're evaluating vasculitis?
Yeah. So when it comes to the other immunological condition, especially when you're looking at a pulmonary involvement, the most common disease is lupus. So an ANA more than 1 in 160 is taken as significant. So this should be N titer of 1 in 160, and the immunofluorescence staining happens 2 or 3 plus. That is called a significant ANA. Now, one thing I always find is people think bigger the better or more the better. So everybody automatically does an ANA profile which gives an immunoblot of various antibodies. I want to make it a point that those ANA profiles or various antibodies are for certain specific conditions. And you can easily miss a lupus case where all these can be negative and only ANA strongly positive. So that is why when you ask for an ANA, do an ANA by immunofluorescence. If the immunofluorescence is positive, then you can go on and do a profile. Complements are a very important, useful test. That is because hypocomplementemia is always a very important feature of an immune complex mediated disease like lupus. For example, if you take the kidney biopsy of a lupus patient versus kidney biopsy of a ANCA vasculitis patient, the lupus patient has a dense immune deposits. So it is an immune mediated disease, whereas the kidney biopsy of an ANCA disease has pauci-immune, that is, you hardly find immune complexes. So if you find the context of a low C3, low C4, or either one of them, it is more suggestive of a lupus-like illness. The other important differential is an antiphospholipid syndrome, because emergencies like your patient with an alveolar hemorrhage could easily be a catastrophic APLA syndrome, where you have pulmonary hemorrhage, and it is evolving to involve the other organs. So there I would also do the three important antibodies, which is lupus anticoagulant, anticardiolipin antibody IgG IgM, and a beta 2 GP1 IgG IgM. The rest of it, and anti-GBM is obviously an important differential here. I wouldn't worry about myositis panel, because alveolar hemorrhage, alveolitis, or pulmonary hemorrhage or pulmonary vasculitis is extremely rare in myositis. The myositis panel gives you a different variety of diseases. So I would not waste, because each myositis panel costs anywhere between 12,000 to 20,000 rupees in our hospitals. So I would not waste my time on a myositis panel.
So, Dr. Ramesh, today only one of my patient, I got this report, so rheumatoid factor is 307, anti-CCP is less than 7, and ENCA is positive, PR3 positive. Now, how do I interpret this report?
Yeah. So rheumatoid factor can be positive in a variety of rheumatological diseases. It can be positive in about 20 to 30% of normal adults, especially the elderly. As you age, your rheumatoid factor positivity rate increases. But in all these instances, the benign conditions, the titers are low. In patients like this, you can expect even rheumatoid factor positivity has been described across all autoimmune diseases. So I would not worry too much about the rheumatoid factor positivity. CCP positivity has a better sensitivity for a diagnosis of rheumatoid arthritis, but CCP positive is also well described in lupus. So you have to be aware that about these things. So I would keep it aside and more go by the clinical presentation than only by the autoantibodies. If my clinical presentation favors a vasculitides, I would take the P-ANCA more into consideration than the rheumatoid factor, and especially if your MPO is also significantly positive in high titers.
Sure. Thank you so much. Yeah. So let's go to the radiologist on board, Dr. Nikhil. So what's the most common ILD pattern in ENCA vasculitis?
Before answering that question, I would like to tell everyone that there are 1029 logins at this time. This message has been forwarded by Dr. Krishna. And also, Dr. Krishna has politely asked Dr. Dinesh to please adjust his camera. His face is not good. So, coming to the question, ma'am, thank you for this wonderful question. Now, the ILD and vasculitis may coexist in up to 10% of cases. And more commonly, these are in myeloperoxidase, MPO, rather than proteinase 3. So, the patients with ILDs and MPO ANCAs, but not PR3 ANCAs, are at a risk for development of microscopic polyangiitis. So the ILDs are divided into UIP or non-UIP type in these patients. The non-UIP type being NSIP, organizing pneumonia, bronchiolitis, and other unclassifiable fibroinflammatory findings. So the most common being still in these are the UIP pattern of these ILDs.
That's great. So I would like to just quote one paper, which is from Boston. What they say is that, the MPO pattern, that's correct. Around 45% of the patients have UIP, 21% has got OP, 11% NSIP, and the rest are LIP, HP, and all. So this is a very nice paper if people would like to read, and which has been published in 2023 by Doliner et al. From Boston, Massachusetts. Let's go to you again, Nikhil. Any tips of particular radiological patterns? You very nicely, in your talk, given the description of, but particular tips or a pattern or a sign which would help us in narrowing the differentials, and which would probably aid us, aid us towards the vasculitis?
As there are variety of symptoms and signs in these which are undifferentiable from malignancy, infection, thromboembolic disease, connective tissue disorders. Somehow, I'll try my best. Large vessel vasculitis have signs of ischemia, fever, myalgia, arthralgia, malaise, and often accompany small vessel vasculitis. Also, unusual constellation of signs and symptoms like involving multiple systemic organ systems simultaneously or subsequently should raise a possibility of vasculitis, such as uveitis, rashes, arthritis, frequent sinusitis, or atypical rashes. So in my first slide also I had given these symptoms like deforming ulcers in the upper airway, palpable purpura, peripheral neuropathy, RPGN, a diffuse alveolar hemorrhage with glomerulonephritis or without glomerulonephritis, and chest findings of nodular or cavitary disease. When these symptoms and signs are present alone or together, we should definitely suspect vasculitis or give it as a differential test.
All right, Dr. Gupta. Yeah, thank you. So let's go forward. Dr. Naeem, this is for you. What's the role of bronchoscopy in pulmonary vasculitis?
Okay, the role of bronchoscopy in pulmonary vasculitis. So, since this being an invasive procedure, minimally invasive, I would say we are having a young, enthusiastic pulmonologists nowadays all over the country. So, our first thing in doing the bronchoscopy will be to rule out the infectious causes, for which we do a bronchoalveolar lavage, send it for cultures and other things. Second possibility for doing the bronchoscopy in these cases will be to have an airway assessment. We have subglottic stenosis, tracheal stenosis, or the third possibility in this case will be the diffuse alveolar hemorrhage, where we do a serial sequential lavage. We have a hemocytin laden macrophages with a greater percentage of more than 20% suggestive of diffuse alveolar hemorrhage. And if we go on to the invasive part of bronchoscopy, that is the biopsy to establish a tissue diagnosis, we have transbronchial lung biopsy, in which the yield is less than 50%, the paper I already quoted in my presentation. But if we go at the same time with the surgical lung biopsy, the yield is high, but the complication rate is also high. So if we have a good clinical background which is suggestive of vasculitis, and at the same time positive ANCA, which will be aided by the this ELISA testing, in this scenario we should obviate it. This obviates the need for bronchoscopy. So we have to be selective while doing bronchoscopy in sick patients. But yes, if we have to go for a tissue diagnosis, which is important in these cases, yes, we should go ahead with these bronchoscopic procedures. Just a short, we in GPA we have endobronchial lesions. Most of we find endobronchial lesions. So there we have to go for biopsy as well as BAL to have the diagnosis. Well, as in MPA we have mostly the diffuse alveolar hemorrhage. So this helps us in the diagnostic to clear the diagnostic dilemma.
So visualization plus the diagnosis, right?
Yes, absolutely.
Thank you. So let's go to Dr. Vamsi. Vamsi, is there any role of a biopsy in a patient who is ANCA positive with an ILD without a systemic involvement?
Yes, madam. Yeah. Yeah, before going for because there is no systemic involvement here, it is very clear that there is only one organ involvement, that's the lung, and probably then, um, and as we have already been seeing on the forum that the most common pattern is UIP, as you have said in the Boston study also. So if there is a clear-cut pattern of UIP in the AAV ILD, then probably we can obviate the need for lung biopsy, because UIP pattern is pretty specific, and I don't think we need anything more than that. But if the pattern is non-specific, if there is an overlapping pattern, and if there is a pattern wherein there are features of coexisting fibrosis, which might be a sign of previous hemorrhages or anything, and when we are actually not sure whether to start the patient on anti-inflammatory or anti-fibrotic, if way we want to go, then probably a lung biopsy would be reassuring. Otherwise, if the pattern is clear cut on the AAV-ILD, then probably we should be thinking in lines of whether to treat with anti-inflammatory or anti-fibrotic. But if the pattern is unclear, there is no other systemic involvement, we are not having clear-cut diagnosis, the immunology part and the serology part are all negative, we don't have any antibody in hand which might say that this is an AAV related ILD, then probably we'll have to go for a lung biopsy.
So I agree with you totally. So yeah, when you have an UIP, it's a clear cut. It probably doesn't need a biopsy at all. But when you have an NSIP or you have an OP pattern, right, or you have a GGOs, where you are looking at some sort of underlying inflammation, of course, then that probably calls for a biopsy, even if the patient's in a ANCA positive patient. And I want all the panelists to chip in and give your out on this whatever questions that we are asking. It's not that I'm asking to Vamsi. Dr. Naeem cannot put, give the inputs, or Dr. Ramesh or Dr. Nikhil or Dinesh. So whatever is there, if anyone wants to answer that particular question, just raise your hand and we will ask the same, forward the same questions to you. Can I go to Dr. Dinesh now? Dr. Dinesh?
Yes.
So, in an UIP pattern, which is NPO ANCA positive, would you treat that patient with anti-inflammatory, or would you treat with anti-fibrotic, or would you, straight away start with both?
In short, yes, both. It again depends on which stage the patient is presenting to me. But yes, in short, if at all there's a UIP pattern there, I would definitely start in for both, because we need to.
So you would start with anti-fibrotics and anti-inflammatories.
Yes.
So would like to give an immunosuppression. Dr. Ramesh, is raising the hands.
A rheumatologist always differs. Yeah, so the essential difference, see, ILD pattern or a UIP pattern is extremely rare in vasculitis. Even in ANCA-associated vasculitis, it is an extremely rare presentation. In these 20 years of my practice, I've seen only 2 UIPs in the context of an ANCA-associated disease. And it is mainly in microscopic polyangiitis. The difference between the UIP of vasculitis versus UIP of connective tissue disease is the pulmonary fibrosis here is due to chronic DAH. If you biopsy the ANCA-associated vasculitis patients, you might on histological examination see a UIP pattern, but you should ask your pathologist to do a pearl stain, because you will invariably see hemosiderin-laden macrophages. So the pathogenesis or the pathophysiology of fibrosis in ANCA-associated vasculitis is pulmonary vasculitis microbleeds leading to a fibrotic reaction. So if I find such a thing in a patient with ANCA-associated vasculitis, I would treat them as like any other organ involvement for 2 reasons. One, the lung prognosis, even though the presentation is that of UIP, will be rapidly progressing, unlike the other UIPs of CTD, which slowly progress. So the mortality rate is much, much higher here. Second, those with ANCA-associated UIPs are bound to get other organ involvement, particularly renal, sooner or later. Hence, my choice of therapies for these patients would be intense immunosuppression, like how I do with other organ involvement involving steroids with cyclophosphamide or rituximab, whichever.
So, Dr. Ramesh, I would like to differ a little bit, because when you have an UIP pattern, nobody would tend to biopsy, not a single pulmonologist. And when they come to a pulmonologist, they've lost the window of a biopsy also because, the FVCs, the vital capacities are pretty low. The pulmonary artery pressures are a little high, and there's a huge risk of biopsying those patients. Now, when you have a honeycombing or a traction bronchiectasis, right, whether it is post-alveolar hemorrhage or anything, it's already a, end-stage lung disease. Right? Yes. Why not start an antifibrotic straight away? And even now, the EULAR classification of 2023 also says the same, that you just see, honeycombing of a UIP pattern. It might as well start with an antifibrotic rather than an immunosuppressive, which probably would cause a harm to the patient rather than any benefit.
So, as I told you earlier, the ILD in or UIP in vasculitis is extremely rare. That's number one. Second, whenever you get an ANCA positive, when you're screening an ILD patients with autoimmune disease, please be careful because amongst the two ANCAs, C ANCA and P ANCA has a lot of false positives. And P ANCA is what is associated with UIP. So you have to have a significant titer of P ANCA in a patient with UIP. Third, you wouldn't suspect just because ANCA is positive out of the way systemic vasculitis. You will be carefully looking for other in system involvement. So if you find a patient with, about 20 RBCs in the urine, which is a very subtle sign, I would think more in terms of ANCA-associated vasculitis and would go for immunosuppression. My rule is about very careful interpretation because this is one of the rarest manifestations of vasculitis. It is not a common manifestation.
All right. Does anyone want to add something?
Yeah.
All right, Dr. Naeem, please.
Yeah, what I have gone through the literature on the same aspect is that like we have MPA-ILD, microscopic polyangiitis ILD, it should be stabilized with a potent anti-inflammatory therapy. It should be stabilized with the potent. Now, if we have an MPO-ANCA positive ILD with a UIP pattern, including pulmonary fibrosis with ILD having MPA. So in these cases, despite anti-inflammatory therapy, we should substitute it with an antifibrotics because in these cases, the prognosis is poor, and at the same time, we could have a multidisciplinary discussion in these patients, but these patients give us lesser time. So we should not take the risk of just inducing them with the antifibrotics.
So, Dr. Naeem, which antifibrotics would you like to use in such
I think we are having head-to-head studies between Nentana and pifedronate. So both are equally good. So there is no differentiation between the two. Both are equally good in the cases.
Dr. Ramesh, I would like to ask, nintedanib has a tendency for this angiogenesis. So, I'm not sure, but, that can lead to some sort of an
hemoptysis,
or a hemoptysis in those patients. So, are we justified in using a nintedanib in such patients, or we should straight away start with a pirfenidone?
See, in the first place, the data for nintedanib is only in CTD ILD. Sure. There is no data for vasculitis ILD. And even amongst the CTD, if you look at it, even the data for isolated CTD is poor. The nintedanib trial only had a subset of patients, small subset of patients who had CTD. And amongst the CTDs, scleroderma and mixed connective tissue disease were the two predominant diseases. So whatever we know from scleroderma literature, we are extrapolating it to all diseases across rheumatology, which is wrong. So what happens in scleroderma is completely different from what happens in vasculitis. So I would, go slow on antifibrotics here. That is why I said I would push more for immunosuppressive therapy. See, rituximab is very commonly used in scleroderma ILD, myositis ILD. It's a good drug. If you're worried about cyclophosphamide, give rituximab. Rituximab is a good drug. And that works for vasculitis as well.
Sure. All right. So, Dr. Dinesh, I would like to ask you this: and what would be the role of biologicals in, EGPA?
Definitely. Now, biologicals may offer an alternative to high dose steroids in my perspective, and I've seen my patients benefit from that. And also, recent studies have also shown that they've tolerated the bemarituzumab and resulted in corticosteroid free clinical remission for the majority of the patients. Of course, it again depends on the severity of when the thing there. So I would always say that you can use the biologicals in eosinophilic driven inflammation, which may prolong the time to relapse and reduce the adverse effects of the steroids. But in case you have to give steroids, of course, yes, it again depends from patient to patient. But I definitely would go in for the biologicals. And of course, there are a lot of data which are coming.
And your selection of which biologicals would you give?
I know now the recent study also says the benralizumab is equally good for all the things. Of course, but again, the question boils down to the affordability and the availability in the Indian context. But yes, definitely the recent studies have shown the benralizumab, and I think I would go for that.
So the EULAR guidelines have recommended mepolizumab.
Mepolizumab 300 mg for 4 weeks. Yes.
For the induction of therapy. Yeah. So,
but what I'm saying is of the recent studies which has shown that this has nothing. Benralizumab is not inferior to mepolizumab.
Of course, sure. All right.
Can I just add something?
Sure.
With respect to the biologics, mepolizumab is expensive. A monthly course of 300 milligrams is about 60,000 rupees in India, which is unaffordable. The published data for mepolizumab is only for non-serious EGPA. Serious manifestations of EGPA don't even have a data for mepolizumab. So as it stands today, the treatment for any serious manifestation of EGPA will still be cyclophosphamide or rituximab. I think that is where India stands as of today.
All right.
Rituximab, I would say definitely yes. Giving it in 6 months or 1 month or rather yearly, that would definitely help in the remissions as well. Definitely yes.
All right. So let's go forward. Dr. Vamsi, what are the challenges for the acute presentation of diffuse alveolar hemorrhage?
Like in acute presentation, if diffuse alveolar hemorrhage presenting in acute presentation, yes, of course, it's very challenging, madam, because we really don't know what is the probable etiology of alveolar hemorrhage. First of all, we have to affirm whether it is diffuse alveolar hemorrhage or not, for which we might need a bronchoscopy and hemocentral macrophages on BAL. And after affirmation, probably we'll have to rule out other things like infections and then other systemic involvement. We have to see for any extra pulmonary symptoms and signs or any history in those patients, because in a patient presenting with diffuse alveolar hemorrhage in acute setting, it's mostly in the ICU, and we might not be able to do many accessory tests as well. So once we affirm that it is diffuse alveolar hemorrhage, then the next step would be ascertaining the cause of DH, whether it is a capillaritis or a bland hemorrhage, whether it is autoimmune in nature or whether it is vasculitides in nature. Or so we might take the help of some lab investigations. We might take history of fall in hemoglobin in the recent past. We might take help of peripheral signs like in autoimmune diseases, like if there is any phenomenon, or we might also take history of smoking or vaping, which is also recently has been described vaping as drug history again. And if the patient is, especially if the patient is an elderly who is having a chronic UTI, then probably history of usage of nitrofurantoin. Or if it's an elderly patient who is having cardiac issues, like history of amiodarone usage. So all these things, along with history, with signs, with some lab tests, because we may not have much time for lab tests. Again, just like your initial case presentation, all of the tests take time. So approach should be very much tailored in a broad categorize it, whether it is infectious or non-infectious, and then whether it's inflammatory or not, and then If it is inflammatory, then what kind of inflammation is going on? And once we are certain that it is inflammatory, by ruling out other infective and septic causes, probably, then we'll have to start them on some kind of anti-inflammatory therapy, and then go on along with other investigations, whatever extended investigative panel we want to go upon.
Yeah, that's Chris. So, Dr. Jois, I would like to ask this question to you. This has probably been bothering me for quite some time now. So, how do you differentiate between ILD secondary to, ANCA associated vasculitis and isolated ANCA positive IAPs?
Sorry, what was the second part of the question?
So, how do you differentiate between ILD, which is secondary to ANCA associated vasculitis, maybe MPO vasculitis, and isolated ANCA positive IIPs, idiopathic interstitial pneumonias?
It is not going to be easy to differentiate unless you have other clinical features to account for either of them.
Sure.
As I told you, ANCA positivity, particularly MPO ANCA positivity, is very well described in a variety of immunological conditions as opposed to C ANCA. So we have to be cautious in the interpretation of an MPO ANCA. That's number one. The significance of the titers, when you have only immunofluorescence and negative ELISA or a very low titer ELISA, then you have to be careful. Then carefully look for other etiologies or other diseases, because in autoimmune diseases, antibodies need not be so specific. You can get ANCA positivity in lupus, you can get ANA positivity in vasculitis. All these are well described. CCP positivity in lupus. So antibodies overlap. They do not define syndromes 100%, especially when we are faced with rare situations. By and large, to classify them commonly, yes. But when you're talking about rare situations, be cautious in interpreting these tests.
All right. So now this is a question to all the panelists, and I want to, every one of you can answer. So what considerations exist for patients in terms of monitoring, evaluation, and relapse? So let's start with Dr. Naeem.
I didn't get the question.
The question is, what are the considerations which you'll look for the patients in terms of monitoring that particular patient, evaluation of that patient, and look for the relapse?
In this regard, the monitoring has to be paced at a specific interval so that we don't miss on to some new onset of infections, because these patients are under heavy immunosuppressive therapy, and there are chances of opportunistic infections or superadded bacterial infections. So these patients should be based on a regular short-term follow-up, and monitoring in these cases should be in consideration with the vital organ functioning like kidneys and eye testing and other serological testing, which will help us in monitoring these patients.
Great. Dr. Dinesh?
Yeah. See, basically, we need to educate the patient, tell them about the disease, tell them about the follow-up, and also you should give them a logbook sort of a thing to maintain, including the immunization, so on and so forth, what medications are they taking daily, So basically, the main thing would be, the crust would be to, educate these patients. And also, whenever they come for a follow-up, you have them a thorough checkup, right, from the fundus to whatever, you should do have a fundoscopy and all that stuff. So unless you do that, I think it is going to be difficult. Secondly, the monetary part is definitely a question mark, especially in the Indian population, given the advancement of the medicine. But again, the actual price to the affordability for the patient is definitely one strong question mark. But nevertheless, we should, we are Indians, so we should think of jugards, try to, innovate in whatever possible way to really get them out of the thing. But definitely, yes, educate them, As soon as I come and tell them, or have your secretary, or I do, I'm in a PG institute, so I do have a logbook where I do ask my PGs to follow up with the patients. So in that way, even they do get to learn, and it does definitely helps that way. But in the long term, yes, educating the patient themselves and the family members, teaching them and telling them, and getting a counseling session maybe once a month will definitely help, because this is definitely a long-term proposition and a long-term disease. So we need to look at it in that aspect.
Dr. Vamsi?
Yeah, madam. Here, I have two things. The first thing is regarding the prior discussion on anti-inflammatory versus anti-fibrotic when it comes to treating AAV ILDs or AAV IPs versus, as Dr. Ramesh was saying, I have a direct question for him. As you were saying, sir, because AAV ILD is extremely rare, as you said, but then when there is a presentation which is in sync with vasculitis and the patient is having a UIP pattern, as you said, because there is less probability that vasculitis might have caused the UIP pattern, but then there's another possibility that probably the connective tissue disease underlying, which we may not have unleashed yet in the autoantibodies profile or in the ANA, might have caused UIP pattern. And more so, UIP is more common in idiopathic pulmonary fibrosis, wherein all the autoantibodies are expected to be negative. So in this kind of setting, then probably, if at all the UIP pattern is not related to vasculitis, and probably it is an IPF. And if there are no other features of vasculitis, again, then in that setting, missing on an antifibrotic would be a little harmful, probably. And then I also have one more question as to what is your take on, for example, in interstitial lung diseases, when we do a BAL, the more the lymphocytes, it says the more the inflammation, and we concentrate more on anti-inflammatories. And the less the lymphocytes, the less the inflammation, and the disease is probably progressing. But in case of vasculitis, usually the BAL is neutrophil predominant. So in this context, how will we take the anti-inflammatory therapy forward? And then there is another thing called the progressive fibrosing ILD. Nowadays, the whole concept of ILD patterns has come to whether the patient has features of fibrosis, that is honeycombing, traction bronchiectasis, and all these things, whether these things are there or not. And there are some studies saying that, as you rightly said, nintedanib or pirfenidone have been studied and evaluated only in patients with scleroderma or IPF and all. But there are some studies also saying that once fibrosis is seen, and we have to start on antifibrotics because it could be possibly a PF-ILD. And here I come to the second part of the question of Dr. Sonia, madam, whether in monitoring the patients, probably in patients with these kind of patterns, we have to monitor on CT whether the fibrosis is progressive or not. Because we might need to add an antifibrotic down the clinical course if you haven't started it early. And then we can also, if the MPOs and all are properly done and the CRPs are done, so we can to some extent rely upon whether the CRPs are falling down, whether the MPO ANCA titers are falling down, and based upon that we can get a clue whether the disease is going into remission or not. And if it is a connective tissue disease associated, again, a vasculitis overlap component, then probably we'll have to look through all the parameters. And if the patient is stable enough, we'll have to be monitoring the PFTs, we have to monitor the DLCOs, which gives us the clue whether the patient is improving or not.
So thank you very much, all the esteemed panelists. Last take-home messages from each one of you. Let's start with Dr. Naeem.
My take-home message to this topic will be that there should be a multidisciplinary discussion while managing these patients. This disease does not belong to one specialty, and there has to be a clinical, radiological, histopathological, and lab support to establish a diagnosis and take forward the treatment.
And the rheumatological as well, Dr. Naeem.
Yeah, I have mentioned all the specialties.
Yeah, okay. Dr. Dinesh?
I think Dr. Naeem has put it in very nicely. Yes, we definitely should have MDD and then take it forward. And it's definitely a case learning, and every patient teaches you something. Every patient, every time you just have to be on your toes. So the most important thing I would say to all the clinicians, PGs or whosoever, first of all, your history taking should be up. Your physical examination should be very good. And then MDD. You will have to personally speak to your radiologist, rheumatologist, pathologist, and of course your team. And even if at all the patient is in the critical care, you also have to look at that. So you'll have to follow the protocol step by step so that you get the thing. Later on, in the other phases, you will also have to learn to educate, because if not, they just tend to not to
Dr. Vamsi?
hello.
Yes, madam.
Yeah.
Yeah. One take-home message is that, because we are talking exclusively about vasculitis today, we are talking too much into it. But probably when some patient comes with chronic features of vasculitis into our OP, the first thing is that we should have a very big paranoid ability to suspect vasculitis in that case. And we walk into the ICU in a patient with acute presentation, we should also have vasculitis in one of our DDs. So this is one important thing, probably because vasculitis is the last thing we consider. And second thing is, I just want to share one case which I've seen recently where the patient presented with chronic hemoptysis, have gone to multiple centers, treated for TB as well, but there were no parenchymal abnormalities. In one CT which he got done outside, there was a small soft tissue attenuation along the aorta and along the pulmonary artery. As in all of us, money is a problem, and the patient was not affordable for any tests. The only thing we could do was to ascertain inflammation radiologically somehow, and we went for a PET CT wherein there was a lot of inflammatory uptake around the pulmonary artery, and we could as well see that there was a pulmonary stenotic component followed by a dilatation component. So suspected tachycardia, started him on steroids, and the patient has been doing well. And in another case, the patient presented with DAH. The one thing we missed was doing anti-GBM. We have sent for Cianca, Pianca, MPO, everything. And then we could control we could save the patient from not being intubated, managed and sent him back on biter. And we did a follow-up, and we found that the kidney started getting involved, and then an anti-GBM was done because when he was
Your connection is very poor, Vamsi.
Respiratory. Subsequently, kidneys are involved. So probably, yeah. What I mean to say is that initially it might be only one system, then probably subsequently other systems might. That patient came out to be anti-G. We should also keep a watch on other systems also when we are following up these diseases.
Thank you very much, Vamsi. Dr. Gupta, your final take on.
My final take-home message for all the clinicians here is, please provide us with a good elaborate history so that we can make a proper diagnosis on, and we give you a proper differential on our investigations.
Dr. Ramesh?
So most of the speakers have already alluded to the take-home messages. Important things that I would like to emphasize is, do not over rely on immunological tests. There are a lot of fallacies in the immunological tests. Most of the labs in India are not standardized, especially immunofluorescence studies. There are a lot of people who are doing loads of mistakes in interpretation of the results. So over-reliance on immunological tests should not be done. You should still be a good clinician to make a diagnosis of vasculitis, and a confirmatory diagnosis, where all possible, with a tissue biopsy should be pushed for. Reason should not be given, my patient refused, he's too poor. These are not These are not going to be things that are going to stand in a court of law tomorrow when you immunosuppress them and you find that you're in trouble for immunosuppression. Second important point that I would like to say is, most of the diseases we spoke today are relapsing remitting diseases. So all these diseases, today you might have a lung involvement, tomorrow they're going to come up with ENT, day after tomorrow with another organ. So a constant vigil is important. Fifth, don't be in a hurry to stop immunosuppression. the risk of flares is huge. And when the risk of continuing immunosuppression is actually very small, even in India, which has a high infection rate, whereas the risk of flare is very costly for the patient. Because if it involves a major organ, the mortality is high. So do not abruptly stop immunosuppression or taper immunosuppression very quickly. We still don't know what is the optimal duration of treatment for all these diseases. It is believed that any major vasculitis should be treated at least for a period of 3 to 5 years with immunosuppression. Finally, don't use immunological tests for monitoring. ANCA titers do not reflect disease activity. Just because you found the titer to be high next time when you did it, it does not mean you need increase in immunosuppression. It is all the clinical aspects that are going to determine what you do with immunosuppression. At the same time, a negative titer does not mean that the disease has gone. It only means after an adequate period of immunosuppression, if your ANCA is negative, it only means that your chance of a future relapse is less compared to a patient who is ANCA positive on follow-up. That is all it says. So immunological tests should not be used for follow-up.
Thank you very much, all the panelists. You have thrown a great light and you have cleared the most of the rarest of the rare disease. And I would like to thank you all for spending, giving great time to this CCI webinar on pulmonary vasculitis. And I'm sure the audience is going to take a lot of things from this today. And good night, all of you. Thank you so much.
Thank you.
Thank you.
Thank you.
Thank you very much. Thank you.